Yeah, good day everyone. My name is Onowori Victor. I am a neurology applicant and I will be doing a question and answer session on the Cheng Ching's comprehensive review in clinical neurology. Basically, we'll be going through questions 11 and 14, and this is going to be an interesting ride. Please pardon the background noise. I am currently in a place where I can't control my environment, but we'll try to do our best to make sure that this is worthwhile. So we begin with question 11. We have a 61-year-old woman with a history of diabetes, hyperlipidemia, and hypertension who presents to the emergency department with double vision that she woke up with this morning. On examination, you find that she has a complete left oculomotor nerve palsy and with intact pupillary function. Which of the following is the most likely cause of our examination findings? So when we see this question, we know this patient has diabetes, patient also has hyperlipidemia and hypertension. Okay. She came with double vision, which she woke up with this morning. That's right. You then see that she has complete left oculomotor nerve palsy and intact pupillary function. Yeah, so this patient most likely has an ischemic damage to the oculomotor nerve, and in order to understand this, we need to discuss the anatomy of the oculomotor nerve. So basically, the oculomotor nerve actually has a peripheral aspect and a central aspect. The peripheral aspect carries some parasympathetic fibers, and those fibers actually help with constriction of the pupils. Now we have the central aspect. The central aspect of the oculomotor nerve actually carries the somatic fibers that helps to move the extraocular muscles of the eye, except the lateral rectus and the superior oblique muscles. So all other muscles are moved by the oculomotor nerve, and that actually helps to move the globe of the eye. Now, when a patient has diabetes, basically what happens is that you have three processes that can lead to damage to the nerve. So there are blood vessels that supplies nerves, and whenever you have the deposition of advanced glycated end products, or whenever you have things like the polio pathway, or whenever you have things like the activation of protein kinase C, what happens is that you have narrowing of the blood vessel, and then that can lead to lack of blood supply to that nerve, and that can lead to ischemia and death to that nerve. So when that occurs, you actually have damage to the central aspect of the nerve. Now, if peradventure there was an aneurysm or a compressive lesion, usually a PCOM, posterior communicating artery aneurysm, that will cause compression of the peripheral aspect of the nerve, leading to issues with the parasympathetic innervation, and that means that in as much as the central part is still working, the oculomotor nerve can still perform its work. The eyes move normally, but there will be issues with the parasympathetic fibers, and you have issues with constricting the pupils. So basically, the pupils will be blown out or they'll be dilated. So back to our question, we can see that we have this patient with this diabetes, hyperlipidemia, and hypertension. They said she came with double vision that she woke up to with this morning, and you saw that she has a complete left oculomotor nerve palsy, right? So it's an isolated oculomotor nerve palsy, but then the pupillary functions are intact, meaning the parasympathetic fibers are fine. So from our explanation, that means that most likely we have an ischemia or a damage to the central aspect of the nerve. So which of the following is the most likely cause of our finding? So this is myasthenia gravis. MG will not cause this. In fact, MG usually is bilateral ptosis. Yeah, it will not cause this classical presentation. Next is brainstem infarction involving the midbrain. Well, if the patient probably has this issue, but since the oculomotor nerve is actually located in the midbrain, but it will cause a wide variety of other symptoms. You see other cranial nerve, other neurological symptoms. The next is diabetic oculomotor nerve palsy, which we said is correct. The next is aneurysmal compression of the oculomotor nerve. Remember, we said this will cause a blown out pupil, but the oculomotor nerve will be preserved for D. And then E is neoplastic infiltration of the oculomotor nerve. Now, neoplastic infiltration is seen as a plausible answer, but this was sudden. Yeah, a neoplastic infiltration takes time to establish. And since this patient just woke up to it this morning, it cannot be neoplastic infiltration. So our answer would be option C. Okay, so for question 12, which of the following is true regarding the oculomotor nerve nuclear complex? Okay, so before we even dive into this question, the options, let us first talk about the oculomotor nerve nuclear complex. Now, at the level of the midbrain, the dorsal midbrain, just at the back of the midbrain, we have the superior colliculi. There are actually two of them, so superior colliculus. And in each colliculi, we have um, something we call the oculomotor nerve subnucleus or subnuclei. Now, they occur in pairs, and then we have a pair for the inferior rectus muscle, so we call it the inferior rectus subnuclei. We have a pair for the inferior oblique subnuclei. We have a pair for the medial rectus subnuclei, and these three actually supplies their respective muscles ipsilaterally. So the inferior oblique subnuclei, the inferior rectus subnuclei, and the medial rectus subnuclei all innervate their respective muscles ipsilaterally. That means that the damage in this subnuclei will affect, it will cause ipsilateral loss of function in the respective muscle. Now, we also have the superior rectus subnuclei, yeah, and the key thing to note is that the superior rectus subnuclei actually innervates the contralateral superior rectus. So, unlike the medial, inferior, and the inferior oblique rectus subnuclei, the superior subnuclei, the superior rectus subnuclei innervates its contralateral muscle. Now, we also have a midline subnuclei. Some people like to call it the levator palpebral superioris subnuclei. Now, that single subnuclei, that midline subnuclei, actually sends bilateral innervation to the levator palpebral superioris on each side. That means that damage to this subnuclei will cause bilateral loss of innervation to both levator palpebral superioris on each eye. And remember that levator palpebral superioris aids in lifting the upper eyelid, and the damage will actually cause bilateral ptosis. Next, we have the last nuclei, which is called the Edinger-Westphal nuclei. Now, the Edinger-Westphal nuclei is unique in the sense that it actually sends parasympathetic innervation to the ciliary body, the ciliary muscle, and the iris. Yeah, so back to our question, which of the following is true regarding the oculomotor nerve subnuclei? So the first option says the inferior rectus subnuclei innervates the contralateral inferior rectus muscle. So is that true or false? That is false. We know that the inferior rectus subnuclei actually innervates the ipsilateral inferior rectus muscle. The next is the superior rectus subnuclei innervates the ipsilateral superior rectus muscle. So from our discussion, that is false. We all know that the superior rectus subnuclei innervates the contralateral um, superior rectus muscle. The next is the inferior oblique subnuclei innervates the ipsilateral inferior oblique muscle, which is correct. Yeah. Let's hold that. D. A lesion to the levator palpebral superioris nucleus will not result in bilateral ptosis. That is false. A lesion to this nucleus will lead to bilateral ptosis because it's a single nucleus at the midline that innervates both superior palpebral superioris. And the last option is the medial rectus subnuclei or subnucleus innervates the contralateral medial rectus muscle, and that's false. The medial rectus subnuclei innervates the ipsilateral medial rectus. Yeah, so our next question says, which of the following is true regarding the cause of the oculoparasympathetic innervation of the eye? Yeah, so we've had a little discussion about this earlier. So let's look at the option. The parasympathetic fibers travel on the peripheral aspects of the ophthalmic division of the trigeminal nerve V1. So that is false. We know that the parasympathetic fibers actually travels alongside with the oculomotor nerve. Yeah, so that it actually travel on the peripheral aspect of the oculomotor nerve, and that was false. Now, but a very important question: what kind of fibers actually travel at alongside with the ophthalmic division of the trigeminal nerve? V1. Now you can recall the sympathetic fibers are actually travels alongside with the with some V1, the V1 trigeminal nerve, the ophthalmic division of the trigeminal nerve. So the next question is the parasympathetic fibers travel on the peripheral aspect of the oculomotor nerve. So we established that that's correct. So B is correct. Let's look at C. The parasympathetic fibers travel along with the sympathetic fibers along the oculomotor nerve. That is false. Only parasympathetic. D. The parasympathetic fibers travel on the central aspect of the ophthalmic division. That is false. And then E. The parasympathetic fibers travel on the central aspect of the oculomotor nerve. That is false. What travel on the central aspect is the somatic aspect of the oculomotor nerve that supplies the muscles of the extraocular muscles of the eye, excluding the lateral rectus and the superior oblique muscles. So, so for our next question says, which of the following is true regarding the pupillary light response and the oculoparasympathetic pathway? So the pupillary light response and the oculoparasympathetic um, pathways. Right, good. Now, like we always do before we dive into the question, let us think about the pathways in our heads. Yeah, so this is a diagram of the optic pathway, and basically we have afferent neurons that begins in the retinal ganglion cells. Basically, they carry light stimulation and they travel through the optic nerve, and then from the optic nerve they enter into the optic chiasm, where you have decussation. Now, nasal fibers, which actually carries information from the temporal field, will decussate as the chiasm, and they will travel with their contralateral optic. They will travel in the contralateral optic tract, while the temporal retinal fibers, which are carrying information from the nasal visual fields, will go to the ipsilateral um, optic tract. Now, when they are in the optic tract, they continue, and then some of these fibers actually project into the LGM, which is the lateral geniculate nucleus. Now, as they continue, some will actually leave the optic tract and enter a place called the brachium of the superior colliculus. And when you reach the brachium of the superior colliculus, they will then synapse with something we call the pretectal nucleus. Now, this is actually a very important aspect for pupillary response. Now, each of the pretectal nucleus will actually receive light from the contralateral visual hemifield. From each pretectal nucleus, we now have afferent signals that travels by interneurons. So the pretectal nucleus actually communicate with themselves, and then at the same time, they also send ipsilateral signals or projections into the indica Westpass nucleus, and then also they provide contralateral um, innervations through those same interneurons to the indica Westpass nucleus. Now, the from the Edinburgh Westpass nucleus, we will then have the efferent preganglionic parasympathetic fibers that will then travel through the oculomotor nerve at each side to the ciliary ganglia, which then innervates the iris muscles, the iris sphincter muscle, and then causes constriction, and then it also innervates the ciliary body or the ciliary muscles. Yeah, so back to our question. Which of the following is true regarding the pupillary light response and oculoparasympathetic pathways? So A, the lateral geniculate body is involved in the afferent pathway of the pupillary light response. Now that is false. What is involved in the afferent pathway is the pretectal nucleus. And B, the afferent pathway of the pupillary light response begins in the Edinger-Westphal nucleus. That's false. The afferent pathway actually begins in the pretectal nucleus. Okay, so C, each pretectal nucleus receives light inputs from only the ipsilateral visual hemifield. Ipsilateral visual hemifield. That is false. It's actually from the contralateral visual hemifield. D, the preganglionic parasympathetic fibers originate from the Edinger-Westphal nucleus, and that's very true. And then the last one is the ciliary muscle is activated for accommodation, yes, resulting in decreased curvature, wrong, resulting in increased curvature of the lens. So that's all for now. Thank you for your time. See you in the next episode. Remember to subscribe, hit the like button, and yeah, see you soon.